Good afternoon, everyone, and welcome to our BAPO P&O Day webinar. Thank you all for taking the time to join us this afternoon. My name is Aoife Healy, and I'm part of the education here at BAPO. And I'd just like to thank our facilitator, Laura Barr, and our speakers, Chantel, Eileen, and Alex, for joining us today. We're going to have a really interesting session, really interactive, and get your views and the panel's views on research education and how we can really work together in P&O. So without further ado, we'll get started. So I'd like to pass over to Laura to get the session going.
Thanks, Aoife. Welcome, everyone, and thanks for joining us to celebrate UK P&O Day. P&O Day is organised by the British Association of Prosthetics and Orthotics, so that's us at BAPO, and it's a chance to recognise and showcase all of the wonderful things that our profession offers to the wider healthcare system. So look out for stories of inspiration being shared all across social media and hospitals and universities today. As part of this celebration, we are delighted to bring you today's webinar, which we will explore the role of research and education in raising awareness of prosthetics and orthotics, both within healthcare and beyond. The theme for this year is working together, which means we'll be focusing on collaboration and teamwork and highlighting how effective collaboration can lead to successful outcomes in patient care and service delivery. Working together can describe many of the interactions that we have every single day. We probably don't even think about it. We work between clinicians, technicians, support workers, patients, and other healthcare professionals. So take a bit of time today to reflect on the positive interactions that you have in your role and the impact that you have. Thinking about today's webinar, we'll be focusing on how research and education play a vital role in raising awareness of prosthetics and orthotics by promoting evidence-based practice, improving patient outcomes, and empowering professionals to advocate for our field. This is done through working together with mentoring, public engagement, and academic collaboration. And in doing so, our researchers and educators make the profession more visible and more integrated into broader healthcare conversations. Today, we are delighted to have three leading voices from this field: Dr. Alix Chadwell, Eileen Morrow, and Dr. Chantle Ostler. Each of our speakers will be discussing how their role in research can shape the future of prosthetic and orthotic practice, policy, and education. Each speaker is going to provide us with a 15-minute presentation, and after that we'll have a discussion with the whole panel, and then we'll take conversations from the audience. So now let me welcome our first speaker, Alix Chadwell. Dr. Alix Chadwell is a researcher in upper limb prosthetics at the University of Southampton and is the Vice Chair of ISPO UK. She's also the chair of ISPO International Specialist Interest Group for the upper limb. Her research focuses on understanding how people use different types of prosthesis. Following the completion of her PhD at Salford and her postdoctoral roles at both Salford and Newcastle, she's now undertaking a fellowship at Southampton, where she's aiming to address the hurdles to high quality, large scale research. So Alix, I'll now hand over to you.
Thank you. Let me just quickly share my screen. Hopefully that's showing for you guys. Yeah, perfect. So I'm going to apologise. My screen is showing up on a different thing. So if I'm looking to the right, I'll continue from there. But yeah, thank you very much for the introduction. Today, I'm going to be talking about some of the ways that we can work together to try and improve accessibility of prosthetic research. So a lot of what I do, as well as my research itself, I do a lot of stuff around public engagement and conference organisation and those kinds of sides of things. So a little bit of that is reflected in some of what I'm going to talk about today. I'm actually going to the British Science Festival next weekend for anyone who is based in the Liverpool or Manchester area. There's lots of good prosthetics talks going on. So do take a look at some of the activities for the British Science Festival next week. So to start with, I just wanted to get you all to have a bit of a think back to the first time you ever picked up a research paper. So do you remember what that that felt like. There's sort of a lot of jargon, a lot of dense paragraphs, impenetrable language. Did you find it kind of hard going to get your head around it? I know personally I did, and I still occasionally do. If we fast forward kind of to what we're doing more recently, have you kind of been asked to kind of create a lay abstract at any point and tried to simplify what it is you're talking about in terms of your research? So something that you're trying to create for a general audience. Did you find that difficult? Again, I know that I find it quite time consuming to think of different ways to describe what I'm doing in that simplified manner. And then kind of another idea around that is, to be honest, if you look at your terms and conditions the last time you looked at an app, did you ever just scroll all the way through all of those terms and conditions, not reading anything, and then just click on the I agree and I accept button at the bottom of it? So I think we all do that. And if we reflect on that when we're looking at a participant information sheet, how many pages was the last participant information sheet that you looked at? Did you just kind of flick through and go to the consent page at the end of it? Again, I know I've seen this, I know I've done this, and I know we've all been there. So these are all questions that we need to kind of be asking ourselves as we're creating our research, as we're talking about our research, and as we're trying to share our research. As researchers, I think we're often kind of, we don't necessarily think about the fact that others don't consume knowledge in the same way that we do. That those academic papers can be really difficult to look at. Lay abstracts don't always actually make sense, even though they've tried to be simplified, and we just throw a lot of content at people. When we're talking to people who aren't experts in our field, we need to kind of make sure that they can get their heads around our research studies and what it is that we're talking about. So over the past 6 months, we've been working with a group of public contributors to try and better understand how the people that our research impacts want to hear about research and understand about research, and what does and doesn't work for them. And that's kind of what I'm going to be going into in a bit more detail today. So the work that I'm going to be presenting is part of a wider initiative where a group of stakeholders have come together to develop the UK amputee and limb different research community. So this community aims to give people with limb difference a voice in prosthetics research and to provide them with a platform that empowers them in guiding the direction of research. It was created to ensure that research reaches that community that it is trying to impact and trying to support. And it's hosted through a Facebook group that's managed by our charity stakeholders. So you can see there that among people that have been involved in sort of the early development of this, we've got BAPO, we've got ISPO UK, the Amputee Rehabilitation Research Network, which Chantel leads, BACPAR, and then in terms of charities, we've got Limb Power, Finding Your Feet and Steel Bones, and then there's broader charities that also are working together in some of that work, and it's developing and it's growing as we go. So a big part of involving the community in research is, as I've addressed at the beginning, kind of better communicating our research with the community. So we all know that the research process itself can be quite slow, and we have so many different draws on our time that we often forget that it's been 4 months since we last actually spoke about what we're doing with those people that are involved. And if we go even beyond our participants to those people who aren't involved in the study but are still interested in that research, how do we tell them about our research? Like, there's so much that only goes out as in journal papers or at research conferences, so it never actually reaches those people that it impacts. So to bridge the gap, what we're trying to do is create a single platform for research across the UK, and by bringing together lots of different people's research, there should be more regular posting going on there, and it hopefully will increase engagement and give a voice to the community members who want to hear about and engage with different bits of research. So what have we learned over the past year? At the start of the year, the Institute for Life Sciences at the University of Southampton awarded us some HIFE funding, so higher education, forgot what the I and the F are, institute, I think, of funding, but that was intended to undertake some knowledge exchange work. So the broader community is part of these different stakeholders that I mentioned on the slide before, but this specific small project was funded as part of a knowledge exchange process. So as part of that, we recruited 2 members of staff, and I'd like to acknowledge kind of the significant work that Miranda, Asher and Vim Rajura have done in terms of developing our guidelines that we're presenting today. And we recruited 10 public contributors from the amputee and limb different research community. So these are people with all different types of limb difference or amputations, and we tried to kind of be broad in terms of age range, in terms of the cause of their limb loss, and various other things. And they've been meeting with us twice a month to develop a set of guidelines for researchers in terms of what they would like to see, some do's, some don'ts, and some advice on the stylization of some of that work they want presented with them. And we will be sharing the guidelines in full in the coming months through our various different stakeholders. We're just currently working out the logistics of how we share all of that, but it will likely be linked through various different websites, such as the BAPO website. So I'm going to start with the different types of research and the types of posts that our public contributors would like to see on the platform. So they'd like to hear about completed research. So in terms of this, they're wanting to know about outcomes and specifically understanding about how different bits of research would impact them and affect them, either now or in the future. So if that's in the future, they'd quite like to know how far in the future. I think there's a lot of things where we tell them about this big, amazing thing, and then it takes 15 to 20 years before they see that in the clinic. One example is things like myoelectric hands, the multi-grip hands. They've been around for sort of 20, 30 years, but actually they're only just coming into the NHS. So understanding that process and the timescales is important to our community members. They'd like to know about ongoing research that isn't actively recruiting. So I've heard so many researchers say that there isn't much going on in a study, that they're analysing the data or they're waiting for a paper to be reviewed or to be published. Our public contributors want to know about that. They want to understand the process, the time it takes. They want an update. They'd rather not sit in silence and not know if anything's going on. They'd like to keep kind of touching base with you and understanding what's going on. We've then got ongoing research, which is actively recruiting, and all of the stakeholders are really passionate. This doesn't become a platform just for recruitment, and it's more than that. It's about us sharing and creating impact from our research. But that being said, they do want to know about opportunities to get involved in research, and they want that easily signposted so they can see, am I the right person for this study? So you're looking for people with lower limb difference or people with upper limb difference. They want that to be really clear and easy for them to see. In terms of planning research, they'd like to, sort of the hope is that the platform itself becomes a route for us to better involve and engage people with amputations or with limb difference in the development of research, and it becomes an easy route to us to go and speak to these people to get ideas from them, for them to guide some of our priorities and those kinds of sides of things. So again, this kind of helps us involve them not just as participants in the research, but as co-designers of the research. We've also got updates on research. So similar to ongoing research above, this post will help you to talk to them at other stages during the process. So whilst we're developing methodologies, for example, or again, sharing progress, sharing milestones, and just building that trust and being open about our research with the members of our research community. And then finally, the one that to me kind of has come out of the work as one of the big things is they really would like us to help demystify research and demystify the research process. There are so many concepts that we rely on for the way we describe our research, but that don't make sense to someone who's not from this research kind of world. And those are the kind of things that make it really inaccessible for those non-specialists. That could be things like p-values, or things like the words qualitative and quantitative, like the amount of time it took me to get my head around those two different words. And I know probably a few of you have been in similar situations. Things like technology readiness levels, which help to give an understanding of the process and how long things do take from that early design through to being a product that they can use and can have in the NHS. And also things as simple as like gait curves, we just use them, we talk about them, but actually if you don't use them day to day, you don't understand necessarily what the different shapes and things mean and what is a meaningful difference. So all of that kind of post is something that we'd really like members of the research side who are wanting to engage with the community, as well as all of your research. We'd love you to help support us in creating these demystifying posts. So what's in the guidelines? They include sort of advice on tone, so things like being friendly but professional. They've got things around language do's and don'ts. So for example, using plain English, but keeping language age appropriate, so not oversimplifying it if the content is aimed at an adult. They're advising on the structure of posts, sort of the use of headers and short sentences, there's descriptive titles, those kinds of things. And then a large part of our work has been around layout and accessibility. So in particular, there's been a clear preference towards using kind of clean and uncluttered content, using limited colours, clear fonts and high contrast, and using kind of open, what we call white space, so having space around text so it's not kind of all compressed and cluttered. And as the destination of a lot of this content is going to be Facebook, there's also advice on sort of dimensions. So for example, if you were to put in a really long infographic, a lot of that gets cut off in the previews in the way that Facebook shares that information. So in order to encourage people to click on it, there are sort of suggestions of what that should look like. It's also, interestingly, our public contributors have suggested swaying away from animations or juvenile graphics unless the content is aimed at children. So these are all obviously preferences, but we've tried to group all those preferences together. And ideally, if we work towards those guidelines, we'll develop them as we go and as we learn more and more with our community over time. So these are some examples of the kind of content that they've been discussing and looking at. So this is specifically related to completed research. We did start the process looking at things like infographics and those more detailed posts. And what we've come to here has come directly from those public contributors. So it is that really streamlined, simplified visuals that they're actually really enjoying. So there's different ways we can lay them out, and the guidelines go into much more detail on this and on what they do and don't like from this. So for example, if you go into the guidelines, it talks about that bottom right one needing a bit more contrast between the text and the background because they didn't necessarily find it the easiest to read. But it talks about like how many different headers you should have, keeping these headers nice and simple like this so that they know what they're looking at. These images here are actually used a bit of software which you can click on and you can expand the text. So for example, you'd click on overview and you'd get an expanded paragraph telling you about an overview about that that research. But it's keeping these really clear things, barriers, priorities, suggestions of the kinds of titles that they're quite enjoying. And if we don't have that interactive kind of approach, we can still do this in text-based kind of images. But again, they really like this idea of keeping things simple, not putting too much text in and giving the opportunity for people to then click and read more. So not overloading people too early on. So yeah, the main takeaway I'd sort of say from that is probably about simplicity of the content, the limited detail, and the option to click out and get more detail if you want it. Another thing we've come to is the development of a set of icons that make it easy for the community members to see if a post is relevant to them or if they're interested in reading it. This is intentionally blurred out because I haven't approved some of these icons with the public contributors yet. So these have come from the designs and ideas that they're giving us, and we're developing from that. The one at the top that isn't blurred out, we have approved that. So that's kind of, with each of these, this is just an example. So if we've got a study that is on a specific topic, they kind of want it grouped. So like, is this around components? Is this around advocacy and policy? Is this some information? Is it software? Is it a conceptual or an exploratory study? And having that kind of legend at the top helps them to understand what it is they're looking at. Though kind of, we've been talking about similar things around, does it have ethics or not? Does it have is it a paper that's aimed at upper limb, lower limb, wheelchairs, people with quadrilateral limb absence? So there's all of these kind of things. It's just trying to simplify and have these bullet point things that you can just glance at it and understand what it is you're looking at. And then in terms of sort of the takeaways for me, I think it's that we need to keep the content we're sharing with the community simple, but more regular. So not going into loads and loads of detail on every post, but just having regular posts that come out and just take people through the process and that support them in understanding what it is that's going on in the broader research context. We've got members that want to be part of that research journey from the word go. So from those really early phases, they're keen, they're interested, they want to learn more, but they find often that the way that we communicate with them can be a barrier and can make them feel like they don't understand and they don't know how to get more involved in that research. They want to understand the impact of the research on the community and how to guide research to ensure that it does address their needs. Personally, I've really enjoyed the journey so far, but we are in the early days still. It takes time to create these kinds of communities. We're looking forward to the broader launch, which we're hoping will be in the next kind of few months, and we will share that through BAPO and all of our other stakeholders. And I'm kind of looking forward to seeing what the difference is that engaging with this community can make in both the quality and the impact of future research. So yeah, the guidelines will be shared in more detail. I'm happy to answer more questions about the community itself. I've tried to focus this a little bit more around what we've learned in terms of those guidelines. But yeah, I'm open to any questions.
Thanks so much, Alix. That was a really insightful talk. Thinking about the way that people engage and how they consume research is just such an important topic, and it's something that we probably all experience when we read papers, project outlines, and particularly when we're sharing our own work. So really, really important things to think about. So thank you again for your valuable experience. That was great. As a reminder, we're going to save all questions just until the end, until all of our speakers have presented. So we'll move on to our next speaker. So I'm delighted to introduce you to Eileen Morrow. Eileen is a clinical academic orthotist and an NIHR doctoral clinical academic fellow at the University of Oxford. She previously worked for 8 years as a clinical orthotist across a wide range of specialities, including paediatrics, neurology, and complex trauma. Her doctoral research focuses on developing core outcome sets for children's elective lower limb orthopedic surgery, and she does this alongside other projects on idiopathic toe walking and paediatric sham interventions. So Eileen, I'll hand over to you.
Thanks very much, Laura. I'm really happy to be here to speak to you today. I think I'm going to go a bit more back to basics and just say like why we need to be involved in research as a starting point, really. But thank you really very much, Alix, for that such an interesting presentation. I'll definitely be implementing some of that into my own work. So like Laura said, I'm a doctoral clinical academic fellow at the University of Oxford, and I was a clinically working orthotist prior to that. And the title of my presentation today is Evidence, Empowerment and Equity, Why Prosthetists and Orthotists Have to Lead Our Own Research. And what I'm hoping to get across today is the problems that we face as a profession, where a lot of our P&O research is conducted without consulting any P&O clinicians. And I've highlighted some possible solutions and how you yourself can get more involved in research if you're interested. So as a background, just as to why I'm partly really passionately speaking about this, research is essential to the role of every orthotist and prosthetist. It's one of the 4 pillars of our practice, which means that it should play a key part of every clinician's role, from new graduates to consultant level professionals. And the reason for this is really simple, is because up-to-date research guides our decision-making for patients and should inform changes to our clinical practice and our service pathways. Research empowers us as clinicians to make informed decisions and to tailor our interventions on the latest evidence, which ultimately improves the outcomes for our patients. Research driving improvement is the reason why research delivery is a necessary aspect of senior roles within the Prosthetics and Orthotics Career Framework Guide. And involvement in research is also really valuable for services. Evidence suggests that patients who receive care in research active environments have better healthcare outcomes. By taking part in research studies, services are actively helping to improve the standard of healthcare for each of their patients. However, in spite of the importance of research participation for clinicians and services, P&O clinicians are rarely involved in research prioritization, research design, research conduct, or of intervention design. And the consequences of our priorities and our practices being excluded from research are significant and far-reaching. Research often doesn't reflect clinical practice, and this has quite a big impact. For example, in devices which are in urgent need of investigation being overlooked simply because they're not considered interesting outside of our profession. A clear and current example is knee bracing, which was not included in the original draft of the most recent NICE guidelines for knee osteoarthritis because there's so little research evidence to support its prescription. And when P&O clinicians are not involved, valuable clinical insights are missing in the research, both about the device design itself and about how our clinical services function. And this can lead to unrealistic study designs. For example, research creates a trial with an insole that's much too thick to fit in a shoe, or assuming that a patient can receive a custom device in a single appointment. And professional disempowerment is another real risk. When research studies exclude P&O clinicians from the process by manufacturing orthoses in-house or by black boxing design decisions, we risk giving away part of our professional role and our expertise. We must be involved in research to advocate for our profession, to demonstrate the value of our expertise, and to prevent it from being stripped away by those who do not fully understand it. And there are wider consequences as well. Without engaged clinician researchers, our profession has a weaker advocacy in areas such as funding and policy development. Prosthetists and orthotists who work both in clinic and in research can make the strongest case for resources because they can connect this research evidence to real patient needs. And finally, limited research involvement hinders career development. Other professions such as physiotherapy, speech and language therapy, podiatry, all have growing research cultures in the UK. And the longer we allow research in P&O to be led by others, the further we risk falling behind and the more questions that will be raised about our professional standing. While many of you might be aware of some prosthetists and orthotists who are involved in research, I put together a list of the most recent government-funded studies for over £1 million to show how our voice is often left out of modern, large and well-funded studies. These studies are clearly applicable to prosthetics and orthotics, and the results will impact on our practice, and yet we have been very minimally included and involved, if at all. I'm not intending to pick on these studies or to say that they're not well run. I just want to demonstrate the persistent trend of P&O expertise being overlooked in research. So the first is the Ostrich study, which aimed to evaluate the effectiveness of insoles for children with flat feet and no other diagnoses. And this study was predominantly run by podiatrists. There was no orthotist in the grant application team or orthotist involvement in the research design, to the best of my knowledge. And unfortunately, the Ostrich trial closed due to poor recruitment. They had targeted to recruit 478 children and only managed a total of 134, which is a shortfall of 72%. Orthotic sites were approached to be research sites, but they were not included in the trial design or on the study team. So the barriers for orthotics involvement were not properly addressed, and therefore the ability for orthotists to recruit for this study was limited, and which that may well have contributed to the trial collapse given the large recruitment target. The second is the BASIS study, which is ongoing and compares full-time bracing to nighttime only bracing for children with adolescent idiopathic scoliosis. And a number of you might be contributing to this study and will therefore know that despite it being a trial of an orthotic intervention, the principal investigators for this study is a spinal surgeon, which reduces potential development roles and our professional standing as orthotists who are being managed by another profession, even in a study of our own practice. There's one orthotist named in the grant application, but to my knowledge, orthotists were not widely consulted on this intervention. And I'll show an example of how this is done really differently in physiotherapy trials. The next is the Big Toe Inserts trial, which is ongoing and aims to evaluate the effectiveness of carbon fiber inserts for adults with painful first MTBJ osteoarthritis. Again, there's no orthotist on the grant application. This trial recently started, and I am pleased to say that they did consult BAPO and NOMAG prior to recruitment to ask about intervention and barriers for orthotic services, which is hopefully starting to show a change in the trend of including orthotists in research. But however, the Tread-On trial aimed to evaluate the effectiveness of insoles for plantar heel pain. There's less information available publicly on this study, but again, no orthotist was named in the grant application. Again, the trial closed early due to poor recruitment and was able to draw limited results. However, in this study, orthotic services were not included even as sites, despite the fact that we see these patients. And this shows a clear oversight of our profession and our expertise. And if we had been considered to be involved, we might have been able to contribute to that recruitment enough that we could have seen some results and had some information that could have helped to shape our practice. And I'm not sure how many prosthetists you got on the call, but you may have noticed that I didn't name any prosthetics trial in that. And that's because the government hasn't funded a study over £1 million for a prosthetics trial in the last 10 years. So there are two potential components to this problem that perpetuate each other. One is that P&O clinicians are not empowered to take part in research, and the second is that P&O are overlooked and not invited to take part in this research. To address the problem with research empowerment, we can integrate research to preceptorship programs, apprenticeships, and student teaching. If students understand research methods and how they can contribute to trials and continue to hone these skills in their early career, we can build a profession which is knowledgeable and confident in research and willing to take on any opportunities that interest them. But what I would recommend to each of you that you can help to address this problem is encourage and support your colleagues to take part in research, audits, and quality improvement projects. If we can work together to show that we are research active and capable as a profession, this will help to ensure that we're not overlooked when larger trials are designed. And to address the problem of mandating involvement, I'm less confident in the answer to this problem and very happy to hear suggestions, but my instincts are that BAPO should approach funders to encourage AHP mandatory inclusion in studies that affect their practice. We shouldn't see these large trials that are being funded for multiple millions that don't even ask us how our services run. We should encourage commissioning bodies to include research within service contracts to ensure that our clinicians can help to build their research capabilities and to take up those opportunities that are presented to them. And I would also encourage that if you're aware of a large trial which is relevant to P&O but not able to get involved yourself, then direct the researchers to the BAPO so that our professional body can help to ensure that there is some P&O involvement in the studies that will affect the future of our practice. So to try and demonstrate how a trial could look if we start to implement some of these changes, I'm going to go through an example of a study which has done a brilliant job of including AHPs in the research which affects them. So the SPELL study is investigating the effectiveness of physiotherapy for children with cerebral palsy. And when I was going through the orthotic studies earlier, only one of them had any orthotists on the grant application. So in contrast, the SPELL study includes 6 physiotherapists on the grant application and directly employs 2 full-time physiotherapists to run this study. The physiotherapists at each site are the principal investigators, and therefore they will be credited in the publications and are routinely included in the study feedback, which means that they're able to request changes to the studies where they have identified problems. And the feedback from the latest session is that picture that's on the right-hand side there. And I think the number of post-it notes really show the ability of the physiotherapist PIs to have their voices heard. This is not, they're given a real opportunity to give that feedback. In addition, the members of APCP, which is the Association of Paediatric Chartered Physiotherapists, were invited to the workshops to help design the physiotherapy intervention prior to the study starting, which is what you can see in that middle picture there. This is a real and inclusive opportunity to contribute to their profession's research before it has started. And like P&O, there is variation in physiotherapy practice across the country, and the study wanted to ensure that the trial intervention had buy-in from a lot of centres. Finally, and critically to research sustainability, physiotherapists who are involved in the trial are being trained in how to provide the new treatment, which means that if the study shows that this treatment is effective, they will be able to continue to give that treatment to their patients. The physiotherapist skills are being built through their involvement in the study, and the results can be sustained at the end of the study. And this is something that's often missed in P&O trials, where the device is manufactured outside a service without training for the clinicians and the technicians in the design or the manufacture. And that creates a commercial reliance, missed opportunity to upskill the orthotic service in response for their efforts in the trial delivery, and also means that these research results cannot therefore be continued into clinical practice, and there's a real lag in change to delivery of service. I might be running a little bit over time, so I'll try and make this a bit brief, but if you've been listening to that and thinking, that sounds great, and I really want to get involved in research, but I just can't see a pathway to that, because I think it's easy to look at prosthetics and orthotics researchers and researchers in other professions as being people who are quite established. So I put together this to try and break down that pathway into research. So this first steps is the kind of position you'll be at if you have no experience of any research, you've no publications, you've not been on a training course, you've not maybe been to any conferences. And I'm going to give some advice for people who are at that stage in a second. And then after that is your next steps, which is when you're a very early career researcher. Maybe you have 1 or 2 publications, you've maybe presented at a conference, or you may be on a training course. And again, I'm going to try and give you some practical steps in a second. And then the next stage is pre-doctoral. So you maybe have 1 or 2 small research grants. You have some involvement in research groups, and potentially you've been involved in a multi-center study like the BASIS study or like the Big Toe study. And at this point, you'll be looking to apply for things like pre-doctoral grants. The next stage, when you're looking to start applying for doctoral grants, is when you have a clear track as a career researcher, you have some involvement in the national research scene, and you have several, and by that I maybe mean 2 or 3 first author publications. And then I think the only point at which it becomes easier is postdoctoral is a very obvious stage because you have your doctorate. So if you're at that first steps, you're interested in research, or you feel motivated to take part in some research, but you maybe haven't taken those first steps yet, the aim at this stage should be for you to start to try and feel out how much research you want to be involved in. Just because you start in this path doesn't mean you have to become a career professor. You want to start to establish some commitment to research, to integrate it into your practice, and to establish that you are a safe and reliable pair of hands to give a large amount of funding money to. And my advice at this stage would be to publish everything. If you have your bachelor's degree thesis, if you have done some work maybe on a service evaluation, publish that work. It is a waste of time for people to repeat that work because they don't know that it currently exists, and it's good for your CV to have some publications on it. Participate in any local research that's going on, whether that be part of these multi-centre trials, or maybe some of the other teams you're involved in are doing other types of trials as well that you can contribute to. Get involved in local audits and service evaluations, because that's all about building the same sort of skills in terms of project management, time management. Join your journal clubs, get a feel for what the research scene that you're interested in currently has publishing in it, and join local groups as well. The one I found really helpful at my early career was CAPR, which is a Council for Allied Health Professionals Research, and they have local bodies, so you can join one that's local to you and meet some other research interested professionals. And then the next steps, so maybe once you've moved on from that stage, is to start to understand what area or methodology of research you might be interested in. So as an example, my area of research is pediatric orthopedics, and my methodology is mostly mixed methodology. So I do a mix of quantitative work as well as qualitative work at the same time. And continue to build on your commitment to research and to establish that you are a safe pair of hands to give some money to in order to do this research. Continue to publish everything. I cannot stress that enough. Like I say, it's an absolute waste of time for people to be doing something twice just because you never told anybody that you did it. Apply for some writing retreats. You'd be surprised how often it's easy to get a space on them, and you get some support in terms of publication, and you can build this writing time into your CPD. Try and secure some small grants or local grants, whether that be through your hospital, or for example, I know CAPR quite often give out small pots of money to go to conferences. And apply for some placements or internships, maybe a week or so at a research within a research team is a really useful way of finding out whether you do want to start taking those next steps or not. So these are some resource recommendations. So if you are interested in taking part in some of that further research, these are some kind of starting points. I won't linger on this too much because I'm aware I'm probably going over time, but I'm happy to go back over that if anybody's interested, or just take a screenshot of it. And I guess in conclusion, if I sum up the message that I hope you can take away from my presentation, it would be this. Despite the enormous potential research has to advance our field, prosthetists and orthotists are too often left out of that process. And this is not just a missed opportunity, it risks holding back our profession and diminishing our role as clinical experts. But we can change this, both individually and collectively. We have the power to shift that narrative. If we want to step into research, to lend our clinical insight, and to demand that our expertise is heard, we can transform the evidence base of our profession. And in doing so, we will not only improve the lives of the patients that we care for, but we will also strengthen the identity, the influence, and the future of prosthetics and orthotics. And that opportunity is ours to ignore, or it's ours to seize. Thank you.
Thanks so much, Eileen. Another really important talk there. It's really vital to realise why those of us who are working in the P&O profession should be involved in research. I think your message really hit home when you outlined what happens when we don't get involved in research and how that affects our profession. I'm sure that we can dig into more of the details about how we overcome this once we get into the discussion a little bit later. So for now, thank you again for showing us the potential of what we could get involved in. Again, we'll hold all questions just now until after our final speaker. So with that in mind, I'm pleased to introduce you to Dr. Chantle Ostler. Chantle is a consultant clinical academic physiotherapist and the clinical lead for research at Hampshire and the Isle of Wight Healthcare NHS Trust. She also works clinically at the Portsmouth Enablement Centre in prosthetic rehabilitation. She has over 20 years of experience in the NHS as a specialist physiotherapist, working with patients following limb loss, and she leads research activity within that centre. She's a member of the ISPO UK Executive Committee, and she's the chair of the Amputation Rehabilitation Research Network. Her clinical academic role is in partnership with the University of Southampton, where she teaches on the MSc in Amputation and Prosthetic Use, and she acts as the clinical lead for People Powered Prosthetic Research Group. So Chantle, I'll now hand over to you for our final presentation.
Brilliant. Thank you very much, Laura. If I share my screen, will that jump? Can you see that there?
Yes, we can.
Fantastic. Amazing. So my presentation actually follows on really, really nicely from Laura's, because from Eileen's, because Eileen has set out really inspirationally about why we need to get involved in research and about the real gap for prosthetists and orthotists. And my particular area is obviously more focused on prosthetics, and the government has just funded a £1 million plus randomized controlled trial in prosthetics, and there is also a £1 million plus randomized controlled trial looking at in surgery around amputation for 3 knees and above knee. So there's a couple of studies, but Eileen's absolutely right. Prosthetics has far fewer of these big studies than orthotics, and so perhaps again an area where there is a particular gap. And so I'm going to talk to you now. Eileen's really set out why it's so important. I'm going to talk to you much more about how, and she touched on some of the things that I might cover towards the end of my presentation, but I'm going to talk much more broadly about how you might get involved in research, because we're very aware that a PhD is not what everyone wants to do. Some people just want to be involved in research and keep their knowledge and skills up and to contribute in the way Eileen suggested, but a PhD might not be the option for you. So I'm going to talk through lots of different ways that you might be able to get involved in research. So really thinking about the how of it. One of the first things to think about is whether you're looking for research in your career or a research career. And those two things are quite different. And so you can consider your different options. You can think about how those options might align with national initiatives and funding opportunities. But ultimately, you've got to end up thinking about what works for you. So does it fit with your role? What kind of activity are you going to be able to fit alongside your clinical work? Does it fit with your family life? And your career aspirations. And so I'm going to present a kind of a range of different opportunities that you could use to get involved in research, and also then think a bit more about Eileen's pathway and how you might move towards much more structured kind of research careers. So obviously we talked about this earlier, about the importance of building that research pillar. And so in terms of advanced clinical practice and consultant practice, if we're thinking about moving that way within prosthetics and orthotics, all of us need to be working really hard to look at these kind of 4 different pillars. And we know that the evidence research and development, that research pillar at the end, is one of the hardest to really know what to do with and how to build. And so a lot of the stuff that I'm going to talk about now really can also contribute to developing that research pillar. So one of the things that might help guide you with like what research in your career might look like is the is NHS England's Research Capabilities Framework. And this guidance really kind of digs into what the research pillar might look like at different levels. And so we've obviously got a bit of information within the Advanced Clinical Practice Framework and a bit of information within the consultant level practice framework. But this framework really digs into research. Now, it can be a bit overwhelming because you think you've got 4 pillars and then this framework introduces another 8 domains. And I think one of the first things people say is, God, how am I going to fit all this into my role? And so I think it's about just starting to raise awareness to start with and thinking about different opportunities. You don't have to cover everything, but it's about that kind of guidance for what you could do. And there's a little QR code on the bottom of the screen if anybody wants to have a bit more of an in-depth look at that one. So what are kind of some of the simple things that you could start to do to get involved in research? And so first of all is, do you know your evidence base? Can you even access the evidence base? We're constantly talking about new research and what you might go on and develop, but actually we're sat on a ginormous evidence base, and it might be patchy in places. In fact, it certainly is patchy in places. But actually, before we're thinking about developing anything new, do we know what's out there? Do we know what the existing evidence is? Do you have an NHS Open Athens account? And do you know how to search? And when you're thinking about searching, do you understand that hierarchy of evidence? So if you're looking to use evidence, starting with systematic reviews so that you know someone else has already done that quality search for you, and it can reduce the time you're having to do looking at lots of different papers. When you do have evidence in front of you, do you understand it? Are you happy with critical appraisal? And can you think about how you might take that evidence and use it in care? And there are lots of courses available online, lots of free courses available to think about critical appraisal skills and covering those kinds of things. And you could set up journal clubs to help keep those skills up and develop and discuss skills with others. And if critical appraisal is something you really enjoy, you could also become a reviewer for a journal. And I'm sure POI International would be really keen to have lots more clinical reviewers to really bring that kind of element in so that we can think about whether the research that's being generated is useful for clinical practice. And you can also review grant applications. So all of the projects that Eileen presented will have gone through a grant application process. And they're always looking for clinicians to review the grants to kind of pick up some of these issues that might help some of that public money not go to waste. So again, lots of opportunities that are not perhaps doing your own research, but just engaging in research within the field. What about getting involved in other people's research? And so Eileen's example of the physiotherapists, some of them would have been involved in that study and they didn't write that project. They were just working as part of that team. And so that might be through something we call research delivery. So research in the NHS might be writing your own grants or your own small projects, or it might be delivering other people's at that site. And so getting involved in research delivery is a great way to start to build some research skills, but without having to do all of the hard work of writing and designing the project. You get to support your patients to take part in research. You could become a principal investigator. And so the term principal investigator changes whether you're in academia or whether you're in the NHS. But in the NHS, a principal investigator is someone at your site who's leading the project. And so that could be you. And there's training available through the National Institute for Health Research to help you think about becoming a principal investigator. And then you can join the project steering group so you can learn how the project is run and led. And if you're particularly interested, you could become a research prosthetist or orthotist. And we have one in Portsmouth who works a day a week with me and does research delivery as we run different trials within the centre. So one of the great things about research delivery is it gives you exposure to academics working in different areas. And if you do a really good job and you recruit patients and you engage with the project, you might get an opportunity to join their research group or to become a collaborator on a future grant application. And so within prosthetics, when I started doing a lot of this stuff, these kind of groups didn't exist and the networks weren't available. And so myself and some colleagues at the University of Southampton developed the People Powered Prosthetics Research Group. And there was a couple of us that started it, and it just brought people together who were interested in research within our university, but also really linked to our clinical teams. I also created with Fiona Davies-Smith from Westmark in Glasgow, the Amputation Rehab Research Network, to try and bring clinicians and academics together to kind of get this collaboration going and think about how we can get people involved in research delivery, but also as collaborators on projects. And so, you know, if anyone wants to join that, do get in touch. We have meetings every 2 months. But one of the things people often feel is that they're like, I don't have the research knowledge, I couldn't do this. But it's not the research knowledge that you're going to bring, it's the clinical knowledge. And that is massively lacking across particularly prosthetic research. And I think you can see from some of the failures in the orthotic research that Eileen presented that actually that clinical knowledge is what people need in these projects. So don't get intimidated. You absolutely bring a skill set that is really missing in some of these applications. So you might want to develop your own research. And so, as Eileen mentioned, you can get involved in service evaluation and audit to really start to build those kind of like systematic, evaluative project development skills. You might want to work really hard listening to patients and clinicians to think about what are the problems, what you be focusing on. You could start with a small or an exploratory project, and then you could perhaps build on that to seek funding for a larger scale project. And this kind of route does tend to kind of lead you towards a clinical academic career, although it's absolutely possible to kind of just do smaller scale projects without needing to move on and do a PhD or a master's or anything like that. But what is a clinical academic career? So clinical academics are clinically active health researchers or health researchers or clinicians who are research active. And so it can kind of spin either way. And you're in a great position as a clinical academic to identify priority areas of research from your practice, to apply findings from your research or your colleagues' research or the community's research into your practice, to really make sure that patients and the public are involved in research and that we're not doing projects that are not meaningful to people who will use our services and use the findings. And we are in a position to help our services and teams adopt research as a core part of the business that we do. So how do you become a clinical academic? So you might just start by thinking about current issues that affect patients and clinical services, and maybe investigate them through more accessible routes, perhaps audit, service evaluation, quality improvement. I would really recommend whatever you're doing, you talk to your line managers and build research into your appraisal so you've got that support. Line managers are one of the biggest barriers to clinical academic careers, and some of that is just through lack of communication, lack of shared values around what you're doing. So actually working with your manager and taking them on the research journey with you is a really a good way of making sure that they're willing to kind of support you as you go forward. And then you can think about what clinical academic training pathways are available, and actually there are quite a few. And so clinical academic training pathways, which is where what Eileen is obviously on at the moment, aim to create clinically based research leaders of the future. And so what they do is they fund different fellowship awards. So a fellowship is when you would be funded to do the research, but the funding is also going to pay for your salary. And it will be over a certain period of time, and it might be linked to doing a master's in research or a PhD, or it could even be postdoctoral fellowships where you have less structured training involved. You're able to build a research team that's appropriate to your research area. It will cover the cost of the training, so it will cover the PhD or the master's fees, but it will also buy you out of your clinical role. And you can do it 3 days a week, 4 days a week, 2 days a week, kind of in lots of different structures to allow you to do it, so that you can keep the clinical side of your work going on. And also you'll have a supervisor, a mentor associated with your fellowship, and they help to provide guidance and structure to what you're doing. And there's a little link on the bottom of the screen there to a whole series of videos that have been developed by the community for AHPs in research to help guide people through clinical academic careers and applying for fellowships. But just so you kind of know what the pathway looks like, and this is particularly relevant for us because this is a pathway that's been developed for nurses, midwives and AHPs, it's essentially a series of stepping stones. And so the challenge always is what happens if you can't get funding to jump to the next stepping stone. And what I'd suggest is just keep trying, because often it doesn't happen in the first go. But you might start with internships or pre-application support funds, which help you to do some foundational work around your idea. Talk to patients and the public. Is it a reasonable idea what you're suggesting? Check the evidence. Has someone done this already, or what work's already been done? And start to kind of build a foundation around your idea. And internships can buy you out of clinical time and give you supervision to enable you to do that. You might then want to consider a pre-doctoral fellowship, and you can use this kind of funding to do a master's in research or to build a really competitive application for a doctoral fellowship. For a doctoral fellowship, you use the funding to do a PhD, and this is almost like your research apprenticeship. So you've got that opportunity to kind of learn about research methods while you're doing a project with lots of training and support. One of the biggest challenges for people that do a PhD and want to be a clinical academic is there's hardly any jobs in the NHS to be a clinical academic. There's a training pathway that trains you to be one, but then to get a job is really difficult. So this is a big part of why taking your manager with you is really important, because you can start to discuss options for business cases to create new roles as you finish your PhD. Or you can go on and look for future fellowships to keep that series of stepping stones going. And the Senior Clinical and Practitioner Research Award is a fantastic award designed to stop people kind of dropping off after their doctorate. And it funds you for 5 years to have a couple of days a week for research time, so it can really help you become established postdoctorally. And then there are advanced fellowships to help you kind of move on, and so this kind of series of stepping stones. Something that can help you think about kind of where your gaps are and what you could work on is the Vitae Researcher Development Framework. Can be a bit intense if you're a beginner. If you're someone that's just kind of getting started, you might look at it and think, oh my God. But if you're a bit further down the line, there's quite a lot of kind of information there. But it's really just to kind of give you a bit of an idea again about what you could do. But if the NIHR is a major source of funding for clinical academic careers, the National Institute for Health Research, but it's not the only way to either fund research projects or to do a PhD. And so there are lots of other routes into doing research if you're looking for funding. And pump priming is a fantastic way to do it, just small amounts of funding for smaller foundational projects. And that might help you do some patient and public involvement or to build a team. There's loads of NIHR funding, tons of different streams, all aimed at funding different types of projects by different types of investigators. They also fund a lot of fellowships. So you either get project-based funding or fellowship individual-based funding. And so you can look at what might work for you. The Association of Medical Research Charities also fund lots and lots of different research, and our professional bodies through different training awards and again fellowships, internships. And so I just want to signpost you to an absolutely fantastic organisation that can help you think about what might be a good option for you if you start to look for funding. And this is the Research Support Service, and it's run by the National Institute for Health Research. It's regional, so you can contact them and they'll give you support in your local area. And they can give you advice with developing a study and designing it. They have loads of different expertise, so methodologists, statisticians, health economists, and advice on patient and public involvement. And they can really help review your application, give you feedback, but also connect you with other people. Because once you start moving into project-based research funding, it's a team sport. So you absolutely need to have a kind of team around you that, and sometimes it's hard to know who these people are and how to connect with them. So one of the things I wanted to kind of share with you is what working within the Portsmouth Enablement Centre. When I started some of this activity sort of years ago, I wanted to think about how I could develop a culture of research within our service. And so I was kind of doing things, and then over time I reflected on it and started to put this model together to help think about how you might create research activity and a culture of research within a prosthetic service. And so this does apply to lots of different services, so it could be relevant to orthotics, but the example obviously I'm going to use is the Portsmouth Enablement Centre. And so we've got 5 kind of different areas I'm going to quickly talk through, but a real key is the leadership. And when I originally did this model, I didn't have the leadership sitting around the outside, and it was a colleague of mine that said, actually, you need someone that's going to drive this to make it happen. And so I added the leadership, and I realised how important that was. So in terms of partnerships and collaborations, what we did at the Portsmouth Enablement Centre was look for research delivery projects. So projects like Eileen suggested, that we're looking for prosthetic centres to recruit patients. This allowed us to have more people involved in research than just me. So other prosthetists, physios, nurses were able to get involved in studies. We worked with the University of Southampton to create this research group to give us a bit of identity. And I developed the amputation rehabilitation research network. And those partnerships and collaborations allowed us to kind of build relationships with people where we could develop research in the future. We started to really think about how we could get research as something we talk about a lot more. So we added it to the agenda of all our meetings. We linked it with our improvement work planning. So it was research and improvement. And we tried to think about how we could use our routine clinical data that was sat within and for us, it's Meditech, within the Meditech system, to be able to do research. We talked to patients, so we linked with our user group, and the People Power Prosthetics group did a project looking at patient priorities, and we produced an infographic. And some of the patients from our user group are now patient applicants on our research grants. We use my PhD research as well as the NIHR portfolio, which is a list of all the studies that are going on in the UK. And you can just go on it and search amputation or prosthetics. You don't get very much, particularly in prosthetics, because there's not huge numbers of studies. But it's if you find studies, you can then email the lead for the study and say, can we get involved in this study? Can we recruit patients for you? And that's a great way for the team to start getting involved in research. This led to a research prosthetist role because we had more and more delivery research coming in, and the team started to access some of the mandatory training around research, like good clinical practice. And then these collaborations led to more homegrown research. We also wanted to really think about how we could get that evidence into practice. And so we held journal clubs, built relationships with our librarians so they could do the searches for us. And then we're working towards monthly update meetings where we think about like what's been published, what might be useful, and do we need to implement that in clinical practice. And then finally, the leadership. So a named person as the research lead. And so for the Portsmouth Enablement Centre, that was me. But then we do have different people leading on different elements of the research, and really think about what our kind of objectives are for research and improvement work across our team, and kind of come together to work on that. So that's a bit of a kind of an example of some of the things that I've talked about actually in practice. So I'm going to finish there. If you do have any questions or any about any of the things I've kind of talked about, I'm more than happy to answer. So you can just email me. My role within Hampshire and Isle of Wight is I do this kind of capacity building and research for the organisation, but I'm really keen to help support within prosthetics and orthotics as well, because I know it's so hard to get into research. So yeah, if anybody needs any help, do get in touch. So thank you.
Thanks so much, Chantel. That was really uplifting. I've taken loads of notes myself, so I'll probably be one of the people that gets in touch with you. Hopefully your talk shows all of us that there's many different pathways to get involved in research, and it doesn't have to be scary, because at the end of the day, research should just be part of our day-to-day role, and it doesn't necessarily have to be a standalone career. So thank you for showing that to us. I think this has been a brilliant session overall. All of the talks have really complemented each other, and there's certainly lots of food for thought. So what we'll do now is we'll move on to a bit of an open discussion with our panel, and then afterwards we'll open up the floor to any questions. So I'm going to pose this question to our panel just now, and if anyone's got any questions, you can pop them in the chat, and then we'll come to those afterwards. So just as we've got on the screen there, I'll ask each of you, how do you think that we can work together across professions to build greater visibility and understanding of prosthetics and orthotics? Don't know if someone wants to step up first or if I'll pick one of you. Go for it, Chantel.
Yeah, thank you. So I think it is really, really challenging, this kind of visibility, and I think we're kind of talking about like perhaps physios being a bit further along with this, and I think it's then using those kind of role models as way to think, actually, if the physio can do it, then why can't I do it? Like, there's no reason at all that that it's something that is exclusive to kind of a physio in your team or what have you. So I think role models is particularly important, and because I think often people can't kind of be what they can't see, so I think promoting some of those kind of role models and those sort of stories of different journeys to help people think about the different ways to get in research, but a really kind of multidisciplinary approach. I think the other thing that I'd really encourage is get involved in networks, and I feel like it's a bit of a plug for the ARN, because interestingly, the ARN has very few prosthetists that are involved, despite loads of promotion and advertising and what have you. We would love to have more prosthetists as part of the network, but we have got loads of physios. And so some of it is just about people who are keen to get involved, and so, you know, come along and join the network, and part of that is about visibility of projects, visibility of academics, visibility of collaborations, and so get involved in these kind of networks to help learn more and to find out what opportunities there are.
Yeah, I think that's really important, and thank you again for all of your insights on that. Alix and Eileen, do you have any thoughts on this one?
Yeah, I mean, I'll build on what I'll build on what Chantel said, in that I definitely have found in my own career that having a really strong mentor, and I'm actually my primary supervisor for my PhD is outside of my own profession, and it was completely transformative. So my primary mentor is a pediatric orthopedic surgeon who I really admired his career, and that was something I wanted to emulate. And I think without his support, I wouldn't have considered the University of Oxford as somewhere that I could have applied to. I definitely would have thought moving was necessary to do my PhD, but having someone that just said, like, I don't know why you couldn't, basically, it's really showed me, and I hope it helps show other people in P&O that our expertise and our research is valued at high academic levels. You don't have to be like some out there genius to be taking part in research. It really is just an extension of the role that we're already doing. And I think that role models and mentorship, either within or out with our profession, can help that next generation of prosthetists and orthotists see themselves in these research careers. And I think the other thing in terms of how we can work across professions to build greater visibility is that when we're thinking of professions, I think we need to think beyond just healthcare teams and start to think about policymakers, commissioners, charities, advocacy groups, because if we're not present in those discussions, our profession isn't going to be prioritised when decisions are being made about funding, are being made about research delivery, are being made about service delivery or guidelines. And other small professions like speech and language therapy have had really good influence in these spheres by being visible and well represented. And I think we can learn from some of that example. It's not, sometimes I think we get a lot of criticism when I say like the physios can do it, why can't we do it? Which is what Chantel's saying as well. Sometimes criticism comes where we're smaller, it's hard to backfill us, like we don't have as much of a presence already. But other small professions are managing, and I just think that we need to start making those moves.
Yeah, thanks, Eileen. And to your point about role models, thank you for being a role model for our profession. I think a lot of us have been inspired by the work that you do. And Alix, do you want to give us your thoughts?
I was going to say, I stick my head above the parapet as the engineer and academic in the room, amongst all the clinicians. But like, I think exactly what the others have said around the kind of the ability to bring everyone together to where that can take you to in terms of the different people you're working with. And I think that point about working outside of the professions into all the policy making, all that kind of stuff, is exactly what Eileen's just said. It's really valuable and really important. But if I, as an engineer, had only worked with other engineers, then I'd be designing things that were not fit for purpose for the community they're going into. Like, I see a lot of value in how I've got to where I am now has been through going to Salford, being in the healthcare part of Salford, working alongside P&O professionals, and then building that and working with different multidisciplinary teams as I've gone through. And so I'm a medical engineer by background, but I sort of see myself more as that translational part between the hardcore engineering side and that the clinical understanding and making sure things are fit for the people that we're making things for. So I think that there is a lot of value across multiple different professions of us all coming together, of us utilising all the different ways we all think, as well as the different ways, different knowledge we have from our backgrounds. And I think that changes what the outcome is for the better, in terms of at least what I've seen and the people I've worked with doing it.
Yeah, absolutely agree. I'm sure that everyone in the room is in agreement with that as well. And it just showcases the importance of working together, and the important positive outcomes that we have when we do that. And so we've got one question in the chat, which is about sharing presentation files. We can certainly pose that to our three presenters. We see nodding, and obviously Chantel has put her email address up, and Alix and Eileen are nodding there. So we'll find a way to share those with you after the webinar. We've got one hand raised. So we've got Joe Piera. Apologies if I'm pronouncing that incorrectly. But do you want to pop your microphone on and ask your question?
Hello, it's not a question. My name is João Pereira. Sorry, it's a hard name. Everyone calls me Jay. I'm a student from the University of Derby on the apprenticeship, and I work for Blatchford. Thank you all for participating today. And just wanted to mention that another possibility, as we mentioned, was joint research projects. My background is in physiotherapy, so working with physiotherapists, OTs, biomedical engineers. So joint research projects are also, as it was mentioned before, is quite a good initiative. Also, in terms of the future, so for instance, in terms of virtual reality and simulation, so using immersive technology to demonstrate how prosthetic and orthotic devices work and improve lives. So with some patient history, some clinician histories might be something in the future that can connect through research. And of course, webinars, carrying on with the T-Talks on BAPO and other webinars can really be inclusive and motivate people to join more research. So that would be my input for this question. Thank you.
Thanks. And yeah, I think you're quite right that the more that we share and the more that we collaborate and showcase the work and the resources that are available, the more that we can start bringing people into the research field. Eileen?
Hi, thanks for that. I just wanted to sort of slightly expand on what you're saying, is that I think when we're actually talking about other professions and trying to increase our standing and increase our representation within the kind of healthcare sphere, part of our problem is that other professions only see us in kind of narrow clinical interactions in terms of day-to-day. And I think that means that the only side of us they really see is our patient care side, whereas actually I think that sort of background knowledge or engineering knowledge, manufacturing knowledge, design knowledge, and problem solving skills are quite often unseen, unacknowledged and unappreciated. And I think unless we actively tell people about the breadth of our profession and start to demonstrate that, our contribution sort of risk being a bit invisible. So I think part of that is working alongside other professionals, even in terms of like training and things, like I know part of our degree course, we did some anatomy training and stuff with other professions. And it certainly meant I know an awful lot more about speech and language therapy than I would have known prior to that. And I do think that some of that is really important just in terms of making sure that other people understand our level of expertise and don't just see us as someone that can come in and cut a trim line a bit more comfortable.
Thanks, Eileen. We've got a few questions in the chat and a hand up. Can I just check, Aoife, we are maybe slightly overrunning. Is it okay to take a few more questions?
Yeah, I think everybody seems to be staying, so let's go for a few more if everybody's happy.
Perfect. So we'll go to a question in the chat first, and then we'll come to hands. A really interesting question in the chat. So how do you think that limb patients can support a recruitment campaign for P&O clinicians, as well as support their engagement in research projects with the encouragement of their service? Any of our panel have any thoughts on that, about how limb patients can get involved in recruitment campaigns?
I don't necessarily have an answer immediately off my head, but I think it's a really good idea for it to come for that support to come from both sides. I think there is value in it, because seeing the value that the end user is seeing in their clinicians being involved in research, I think is really valuable. I think it possibly links a little bit into the next question as well, in terms of capacity and time. But yeah, I'll have a think. Chantel's got her hand up, so I'll see if she's got a solution to all of it.
Maybe not a solution. So in terms of limb patients getting involved in recruitment for P&O, I don't know. I might be speaking kind of because obviously I'm a physio, and so but I know your challenges within the profession for recruiting P&Os to train. I think probably the biggest thing that I can imagine limb patients is sharing stories, is the stories of actually like what's happened to you as an individual, and how much of an impact engaging with prosthetic and orthotic services has had on you. Because I don't know about other people on the call, but I know a big part of why I wanted to come and work in the NHS is to help and to make a difference. And I think sometimes people don't understand about these really technical roles. And I remember when I did a research project years ago, and we talked about what are the expectations of your prosthesis and a prosthetic limb and things like that. We talked about that with a group of patients as a qualitative study, and not a single one of those patients mentioned the prosthetist. They mentioned the nurse, they mentioned the physio, they mentioned the OT and the doctor, but no one mentioned the prosthetist. And so we're like, well, what's that about then? Is it just that people don't know about these roles, or is it something more about thinking that leg, not acknowledging that someone's going to actually have to make that leg? But if it was about just that awareness, I think limb patients could really help with sharing their stories and sharing the impact. In terms of research, I think limb patients can help with research in so many ways, and we would absolutely welcome that. The limb difference research community that Alix was talking about is a way that we're kind of thinking about how we can sort of pay back, and how we can make sure we keep people informed, and how we can make that equitable relationship. But actually anybody who is out there who might be interested in getting involved in research, in supporting designing projects, in helping students to create projects. I'm sure, they can absolutely contact me. I'm sure they could contact Alix, and they could join the amputation and limb difference research community to really help make sure that the work that we're doing is meaningful, is not just someone's idea off the top of their head, that it's actually going to have an impact on patients. It's going to be useful.
Yeah.
Also just thinking, just to add to that as well, there's the so that because this community is so early in its development, and if we want the community to drive the development of it, there is every possibility that within that community people with limb difference can lead the direction that it takes. And if what you want to do there is create some sort of campaign that goes out to start to get more different professions involved in the research side of research, if you identify, as we have, that there's maybe a limited number of P&O clinicians involved in that research, there is every possibility that we can get people within that community coming together and doing something that takes that forwards. Say it's such early days that there's those opportunities if that's what the community wants.
Thanks, and thanks for the question, Christopher. Did you have a follow-up comment for that?
Right, Hannah, thank you very much. Just to add what's already been mentioned by Chantel's about the importance of encouragement for patient user groups. And that's also from the trust point of view, as well as time and abilities for us as patients to feed in. We can so help with the first part of my question, which was concerned recruitment, in terms of literally family and friends of an age that younger people would be considering which career to be able to promote, and say the difference that prosthetists, orthotists, and of course our technicians make to our lives. I mean, there is a third-party testimonial aching to be more widely known, and that then encourages feedback. It recognizes the professions in all of their degrees, the physiotherapists, of course, for rehabilitations, where it all starts from raising expectations rather than limiting expectations, because new patients just would not know, and therefore the engagement of experienced patients can vitally make a difference. Thanks for hearing this.
Thank you. And Francesca, I know you're waiting patiently with your hand up, but I'm just going to take the follow-up question in the chat because it ties right into what we're talking about here. So the follow-up question from Sarah Evans is in relation to time. Now, this is the age-old question, isn't it? How do we build capacity for clinicians and for participants in research to have the time to be involved? A sticky question, but if anyone has any thoughts, we'd be delighted to hear it.
Yeah, I can have a go at that one, and I'm sure the other guys might also have some thoughts. It's incredibly challenging time, and I think the internships are probably the research world's attempt at managing the time issue. And so putting out these kind of internships where you might have about £10,000 to play with, and you can buy yourself out of your clinical role for like a day a week for 6 months to be able to do that. The problem is that comes with all the challenges in the world for your manager then, because you're like, if you're going to drop a day a week, who's going to see the patients that will be coming in on that day a week? And it's not like we've got, particularly in prosthetics, it's not like we've got a queue of prosthetists waiting to come in and come and backfill this time. So it is challenging, and there are, I think, probably more challenges from that sense for prosthetics, but that's the kind of solution that they're offering at the moment. One of the things with these internships is that they can be really flexible. And so if this is something you're really interested in and you kind of think, I want to work out a way to do it, get in touch with me, and we could have a think about what might work for you. I've seen people do it in, like, they did everything over a month, and they just did a really intense month block, and they did all the work in that time. Or others who got the award an hour a week, and then used the money to work with a research assistant who did more of the time. And so that it was they led it rather than doing actually all the activity. So there are different kind of ways you can do it, but time is so challenging. And there's no doubt with all of this, there's a point where you have to give some of your own time to kickstart it. And you might have to work in the evenings, and you might have to do a little bit extra just to get things started. And again, that all comes down to whether you want to do that, whether that's the right thing for you or not.
Thank you. Eileen, do you have insights for that one as well?
Yeah, I mean, again, in terms of my own personal journey, I would agree that I was incredibly lucky in that the kind of point in my career where I needed to put in a bit of extra work and extra time was during COVID, when we weren't massively seeing patients anyway. So I was kind of able to give that extra time over, but it did, like, just prior to that, I was doing some evenings trying to put together grant applications. And I think if you're more clever about it, there are ways around it. Things like the writing retreats and stuff. I wish I knew about them when I was writing up my applications. There are also some small grants you can get a hold of that do help this sort of like priming work, so they can buy you back out. But I would agree that I've kind of hit, I think coming from a smaller profession in particular, you do hit a hurdle where it's like no one's going to backfill this role. Like for my doctorate degree, I have all the money to pay myself out and to allow someone to backfill that role, and my department just sort of wasn't able to support that because they just couldn't have found someone to backfill me for 3 years. So it's not to say that we don't acknowledge this as a problem. I think partly in terms of like a profession-wide move, I do think, although again I appreciate there's challenges to it, but I think we need to put pressure on the commissioners to include research as part of our service contracts. You know, this is a pillar of our work. It shouldn't be something that in order to do we squash it into our lunch times or after work. Like, it should be an integral part of our work. And I think that particularly given that we're in a profession where there are more service contracts, we're allowing that to kind of get moved out the way in preference for patient numbers. And I think we would just risk falling further behind professions that don't have those issues. And I think ultimately that is the answer, is to start saying this is a part of our work, you have to pay us to do it. But I appreciate there are barriers to kind of progressing that forward, but I think that the barriers shouldn't stop us from pursuing that as a pathway.
Thanks, Eileen. Francesca, do you want to give us your question?
It was kind of more of a thought, really, and kind of building on everything that's been said. It's been really interesting. Basically, I was just wondering whether in prosthetics and orthotics, why we're kind of so behind with research. Do you think it's anything to do with like a lot of people working for companies rather than directly the NHS? So I do feel a lot, thinking about where I work, that people assume that I'm sort of with a private company and that I couldn't possibly take part in any sort of NHS research because I might have ulterior motives, you know, trying to get sales or something like that. And I was just wondering, you know, whether sort of tackling it from the source and making sure all the different companies kind of try and build in to their sort of new graduates and that this is what we have to do as part of our role as research. I mean, would you agree, if you know what I'm saying?
Yes, Eileen, go for it.
Yeah, I think this kind of follows on from what I was saying, really, is that partly from my presentation, I do think that it should be built into preceptorship schemes. I think it's really important that we build the momentum of people doing their thesis at the end of their bachelor's degree to say, you know, develop these skills more. They are really important for your full career. Don't just drop it so that you can, you know, kind of get your head around seeing patients first. Then further down the line, you're like, oh gosh, what was that all again? Like, I've kind of completely come out of reading papers and stuff now, and trying to get yourself back into it is a bit of a challenge. I do agree that sometimes there is a bit of a funny barrier between NHS funded research and including companies. Sometimes people don't, I think particularly this is a problem with allowing our research to be run outside of our profession, because I know that when I was speaking with a research team who ultimately didn't get the funding for it, but who were putting in applications for the basis, and they were trying to work out, because of the kind of barriers that come in with their own with the way research funding works, and like having to then pay back for certain devices and blah blah blah, They were trying to work out whether they could just do it with NHS clinicians or whether they were going to have to engage the companies. And I think at that point I said, you're going to have to engage the companies. Like, ultimately, that is a large chunk of our profession. But the other part of it was when I said, you know, some of the services are NHS, but their workshops are companies. That was like a whole big other head spinner where they were like, oh my goodness. So there's like, it does create barriers to the way that research funding flows. And so sometimes researchers, I think just in particular in smaller projects, just try and ignore it by just working with NHS clinicians. But then I also think that some of it is that the companies don't get to include research as part of their contracting for that service. They're having to push for that really high patient number so that they can justify the kind of cost of the running, and try to lower the cost of running as much as possible by cutting out anything excessive. And I think that ultimately that means that research gets left at the wayside. And I think that that's something that as a profession we need to move for, so that no individual company feels like they have to leave that out of their contracting for a service. We need to say that this has to be mandated from the CCG side and not from the company side.
Thanks, Eileen. And Alix, do you have some help for us in this one as well?
Well, I was just going to say, like, so from my side, when I've got involved with studies, I've not necessarily, in terms of the engagement with people, I've not differentiated between people who are working for companies versus people who are in an NHS only centre. I'm aware of studies where it has had complexities, and where especially with product development, it can start to cause some problems and things if the company want to work with something but don't want other companies necessarily to be involved in those studies. But more from my side, one of the hurdles I found in terms of being able to engage you appropriately in these things is that when you put together funding applications, especially, as we said, some of the NHS orientated ones, so NIHR, MRC, those kinds of things, there is a costing sheet that if you're an NHS member of staff, there are ways of costing in the time of NHS members of staff. There aren't necessarily those procedures of how do we cost in the time of someone who's actually employed by Blatchford, by Steeper, by one of our companies. So I think maybe something we could do as a community is better understand how should we be, as researchers, how should we be reimbursing or supporting or doing that, and providing guidance to researchers who are putting together those funding applications of how to go about kind of addressing the cost of your time, even if, as Eileen said, it can be a little bit complicated, because yes, as much as we can buy your time, you can't necessarily be bought out by other people, and there aren't people to replace you, and there's all these other hurdles. But maybe something that we can do at our level is give that advice and guidance to people who are preparing applications.
I've actually found it easier to work with the companies than the NHS, because the NHS can be a goddamn nightmare to try and like find your finance person and what have you. At least in the company, they get you straight through to the person and they can tell you the salary of the individual you're talking about. But yes, I think there's swings and roundabouts there, and I absolutely agree. There are some real barriers with the companies, particularly when we're looking at product development, intellectual property, things like that. I think things get challenging. So
I think it's definitely something that a lot of people are interested in. I can see some clapping, smiling going on with the audience. So yes, that's definitely an important subject, and thank you for your thoughts on that. Aoife, I'm going to check in with you again just on time, and we do have a couple of extra questions in the chat, or shall we tie it up here?
Yeah, I think unfortunately we're going to have to appreciate everyone's time from the speakers. I know there's a couple more questions, but hopefully we can continue in these discussions, and we'll have to close the session. I've just put up a slide there. We really appreciate your feedback on this session today, so please complete the form. Thanks.
Yeah, that's perfect. For obviously all of our panelists have said that they're happy for people to reach out to them and to share things. So if you do have any burning questions, I'm sure that they'll be happy to take those from you by email if you contact them. So just to say thank you so much again to all of our fantastic speakers today, Alix, Eileen and Chantel, for sharing your insights and your experiences. And thank you to everyone who's joined us and taken part in the discussion. I think that was really, really interesting discussion, and I've been rapidly taking notes the whole time as well. So I'll be taking a lot away from this as well. Together, I think all of these talks have shown us just how vital research and education is for prosthetics and orthotics, and how important it is to raise the profile of that because we're stronger when we work together across the professions. Just a final note to say that at BAPO, we're committed to supporting research in our profession. We have a dedicated research webpage and a research support policy, and it's available to anyone working in P&O research. You don't have to be a BAPO member to access those resources. So I would encourage and guide any of you to have a look at the website, have a read through those, whether you're just starting out in your research career or you're just thinking about it, or if you're already leading projects. So as we close, I would encourage you to have a look at those, connect with your colleagues, and think about the part that you can play in building the evidence base for our profession. Thank you again for joining us to mark UK P&O Day. Let's carry forward today's theme of working together, because working together with collaboration and shared learning, it's how we'll continue to grow and make a difference as a profession. So thanks everyone, and bye for now.